Welcome back to the channel, Roy Ones. I feel amazing. Why I'm alive, baby, I'm alive. Today, we continue the Health Talk series put together by Complete Health Ventures and the Gentleman's Factory. I had the pleasure of speaking with Dr. Emma Wallace, a vascular neurologist, on strokes, the brain attack. Enjoy. What made you decide this is it? Everybody has those moments.
Right. So for me, this is it has to do with the brain. This is it because the brain is the substance of who you are, in my mind. And what better way than to spend a life devoted to understanding the substance of who you are?
That's beautiful. And when you're saying that, the substance of who you are, was there any other motivations? Like, did you have any people in your family that actually had any challenges with the brain?
Oh, of course. So the matriarch of my family, my grandmother, she had Alzheimer's dementia. And when I first met her, when I came over from England, she was bright and beautiful and vibrant, but was losing herself already. And I watched the progression of her Alzheimer's. And I saw it affect my family. So that was kind of my first little peek into seeing brain dysfunction without understanding at the time what it was. But now, being who I am now and having the training that I have now, having a lot better understanding.
That's amazing. Where do you work at right now, currently?
So, my home base is NYU Langone, the Brooklyn campus, and I just have to say that anything that I say is not representative or an opinion of NYU Langone.
Disclosure.
Or my private practice group, which is IDA Neuro Associate. So home base is NYU, but we actually cover a lot of hospitals. So I work in the capacity of a vascular neurologist, but I'm also doing additional training to be an neuroendovascular surgeon. So that's how I spend my days and my nights.
We're happy that you're doing it. We need more of you out there doing it.
Oh yes, there's like none of me, so we need more of me.
Yeah, I completely agree. So when you're talking about a stroke, what is it? I think the statistics are like insane. Something like every maybe 60 minutes, some outrageous amount of people actually get a stroke, and like every 4 minutes someone dies of a stroke. I mean, what are some of the things that we can do to alleviate some of these things? I mean, because I think that's the big issue.
Right. So stroke is complex. And there are different types of strokes, and the rates of different types of strokes differ. So for the majority of cases, people have what we call ischemic strokes. All it means is you don't have blood flow to an area of the brain. The other subtype of stroke is hemorrhagic or bleeding, a stroke due to bleeding. So on the order of 85% of all strokes that happen are ischemic strokes. The other 15 or so percent are the hemorrhagic strokes. The things that we can do to alleviate, so it really, if we wanted to alleviate, we would need to do something called primary prevention. So that's literally starting with people from when they're kids.
Wow.
And making sure that, they don't stop running outside, on the playground. That they don't start drinking soda, they don't start smoking, right? Because those are the things that put you at risk, some of the things, for a stroke when you're older, right? So that's really where we need to be, but that's very difficult to do. You have to deal with the here and now. And the here and now is the people that do have the things like high blood pressure, diabetes, high cholesterol, have been smoking since they were 13 years old. And, you know, the sorts of things that you have to do is make sure that people are on the right meds. Try and help people to stop smoking.
Seems like that's a big thing. I think it's high blood pressure and smoking are like two of the biggest causes.
Absolutely. If there were literally two things that you could do, it would be to stop smoking and take your blood pressure meds. Like literally, if there were just two things I could get patients to do, it would be those two things.
There's a lot of pushback for taking medication and smoking.
It's hard. Who wants to take a medication every day? Who wants to face or live with the idea that I carry this diagnosis of hypertension? Who wants to lose whatever soothing it is that they get from having a cigarette in their hand? You know, the sensation of the draw, the act of putting a cigarette to their lips, right? Those are all things that are very soothing for people. Why would you want to lose that? Right, and then there's the question of, you know, where do you live in your mind? Do you live in the here and now? So, okay, this draw might be the last one, but hey, at least I enjoyed it.
Yeah.
Or are you forward thinking and can you say to yourself, well, you know, if I quit smoking and I take my high blood pressure meds, that's going to add another 10 to 20 years to my life.
That's a lot.
Yeah, no, that is a lot, right? But you have to understand the mindset of the individual and work with them from where they're coming from. It is hard.
Yeah, and when you say work with them from where they're coming from, I can imagine when you're in the office with them, someone who has had a stroke is in an extreme fear mode. And it's a very sensitive, intense moment. I can imagine dealing with that instant. How do you manage tension in that moment?
You have to keep it real. You have to be. Keeping it, like I was talking to a patient today and she cried. She cried because I told her how lucky she was that she had had a stroke that could have been devastating, but it wasn't. So it's hard, they're uncomfortable conversations, but you have to keep it real. You have to be honest with the individual that's sitting in front of you. I try to be sensitive to people because it's hard.
Yeah.
I think that's just a recurring word that is coming out tonight. But it's difficult having to live with, you know, having had a stroke and the disability that it causes. So we try to provide emotional support when you can. But I think people appreciate it when you're honest. You are honest and you're upfront. And those are two things that I am with my patients.
You said some key factors there, which was sensitive, which you said several times, because I think it is a very sensitive time frame where if you don't have some kind of empathy and no one feels it, I don't think they would be in your space for long.
Oh yeah.
Right? Because it's a bit much.
Absolutely. Who wants to go to a bad doctor, an insensitive doctor? Nobody. Right? I mean, I don't.
What is this? There's an acronym, BFAST.
Yeah.
What is that?
So it is a mnemonic that has been devised to help people kind of understand the symptoms to look out for with regards to stroke. So it stands for B is balance. So if you're having trouble walking when normally you don't, maybe an issue. E is for eyes. So there are certain stroke subtypes where you can have abnormalities in your eye movements. F is for face. So like the classic picture that you'll see is somebody with a droop one side of the face. The A is for arm. So what will happen is, what I look out for is drift. So people might say that their arm feels heavy, or it feels weak. That's another one of the signs. S is for speech. So you produce speech and you understand speech. If you have deficits in either of those, that's something to look out for as a possible sign of stroke. And T is time. So the wonderful thing is that we have medications that we can give to patients if they present to us within 4.5 hours of symptom onset. So if there are any vascular neurologists that are watching this, I know that we have other data that we use, but we're not talking about that data. But 4.5 hours from symptom onset to be able to receive this medication.
And then so after the 4.5 hours, there's a whole different ballgame.
So we are in a different ballgame. It's going to be heavily dependent on the hospital system that you work in, whether or not they have stroke doctors that are present. If you can get rapid access to MRI to help to see, you may still be able to get treated with that medication, but that's far and few between. So the standard is 4.5 hours for that medication. There's more than just that medication that we provide, so the whole endovascular surgery that I mentioned. So patients can have something called a large vessel occlusion. So you have large vessels that feed the brain, and we can literally go in and pull the clot out. Pulling the clot out to help to try to save brain tissue that is at risk of dying.
So is that like a last moment thing?
No, it's not a last moment thing. So that is if you meet the criteria standard of care for patients that are having stroke. One, to be evaluated for a large vessel occlusion, in addition to the medication, the clot busting medication I mentioned. And two, if you do fit the criteria, to be provided with that treatment.
It's interesting. I mean, to have a stroke is very extreme. So the whole point I think about all the time is to be prepared not to have it. And what I think about the most is diet and exercise.
Right.
Dr. Quincy Blackman always talks about exercise and diet and how much he believes in it.
Right.
And how valid is that? How much of a preventative measure can that actually be?
So the three things I mentioned that put you at highest risk for stroke: diabetes, hypertension, high cholesterol. If you are somebody that exercises regularly, if you are someone that eats well, and in the stroke world, we believe in a Mediterranean diet, but they don't understand Black people, so I have to.
This is not spicy enough.
So we have to tweak that a little bit, but but you can vastly improve your blood pressure through exercise. You can vastly improve or reverse your diabetes through exercise, right? So those are just basic things that you can do in order to help to decrease your risk of stroke. Now, again, you have to meet people where they are, right? So you can't go to the patient that just doesn't exercise and say, you have to change your diet, you have to take all these pills, and you need to do 30 minutes of exercise a day, right? You have to kind of take them through a stepwise approach of trying to get them to make the small changes so that they can have the large change that they need in order to decrease their risk for stroke in the future.
So what has been some of the results in terms of when people actually get evaluated? What's the percentage of people that actually get, 80% better, 100% better? Is there such a thing?
So it depends on where you start out. So if you are someone that had a really small stroke, and on day one, say you're not moving your left arm well, but then on day two, you're able to move it, day three, more, day four, you're full strength, maybe you still have a little bit of weakness in the leg, that person is going to do well. The individual that comes in, no movement, not speaking, doesn't attend to one side of space, that person is not going to do well. and I can tell that just from the beginning. So it really depends on the severity of your stroke. I will tell you, another patient I saw today, the reason why I do what I do, beautiful, young gentleman, younger than me, he had stroke, affected the language area of his brain. He had that procedure that I mentioned where you can go in and take the clot out. When I went, I was standing outside of his room. He's in the ICU. He's making his bed. He's walking around in the room. He's talking. And I was like, oh,
Yeah.
like, I'm so happy that you're here and you're okay and you made it in time to be able to get the treatment that you got. I don't want him to have another stroke. You know, he has so much to live for and so much life left. It's actually absolutely beautiful to see. Absolutely beautiful to see.
Yeah, those are the moments that get you up in the morning, right?
Yes, absolutely.
What's the I would say the percentage of people that actually come in and they're on the edge? Because I know a lot of people wait. A lot of people wait, and I know that's a big no-no.
They do. A lot of people do wait, and that's exactly why I was mentioning to you that medication, 4.5 hours, right? So there are people that will say, oh, mom isn't talking, but maybe she's tired, let her just sleep, and I'll see her in the morning. And she had a blow-up stroke. There are people that live alone, right? They're down on the ground, and it takes a neighbor a day or two to figure out that, wow, I haven't seen, my neighbor come in and out for the past 2 days. Like, what's going on? Knock on the door, no response, call the police, and then they end up with me. If there's anything in that BFOS that we went through that's concerning, just go. You would rather be safe and get the evaluation than not have the evaluation. One thing that's really difficult is young people and stroke, because even as physicians we have bias. You're young, why would you have a stroke, right? But they're kind of a special subpopulation of patients with stroke that need kind of a different kind of evaluation. So even if you're young and you like, wow, my arm is weak, why is my arm weak? That's not normal. Go get checked out.
Yeah, most young people will not resonate with that. They'll feel like whatever this is, it'll go away in a couple of seconds. And I think it's because of the diet too, and like you said, playing video games all day, you're not working out,
Right.
Probably have high blood pressure, don't know it.
Yep.
Dr. Jonathan Francois, we had here before, he was talking about how a lot of people just don't get checked out to know, and the reason they have like strokes and heart attacks is because they never got checked out in the first place.
Right.
So if you're in a younger age group, you already feel like you're invincible anyway.
Absolutely.
So it's not like you're gonna say, hey, my arm hurts, I'm gonna go to the doctor.
Right.
So that can be somewhat of a challenge.
Right. It is a challenge. So many times the patients come in and I'm like, okay, we're gonna set this patient up with a PCP, right? Because they can be somebody that can serve as a filter if there's something that they're picking up and that they're worried about. Or even if the patient just gonna have somebody to reach out to. So many people, they don't seek out medical care. Once your mother's not taking care of you, 18 hits, it's a wrap, like you're not going to the doctor anymore. You have to remember that we do need to.
Yeah, I agree. Is there any things that you would want to give the public of things that they should do or should be mindful of in advance?
I would definitely say to remember the components of the BFOS mnemonic. I would say if there's anything that you're worried about, just go, you get checked out. It might be a couple of hours. Hopefully if you get checked out and there's nothing there, but you'd rather be checked out than not checked out. If you have any issues with language, just go. If you have weakness one side of the body, go. If you have numbness one side of the body, go. Just go.
Even if you don't have insurance? Because I know that's
100%.
a big deal.
100%.
Because a lot of people will say, well, I don't have insurance, I'm gonna wait.
Right.
That's a big part of it.
100% just go. We can figure out the insurance. right?
Yeah.
We can figure that out.
Okay. I thank you so much, Dr. Wallace, for giving us your time.
There's 3 main points I wanted to share with y'all with the conversation we just had with Dr. Emma Wallace. One is, it doesn't matter how young you are, if you're not feeling well, go check it out. There's a record number of young people having strokes, heart attacks, and dying. Number 2, move. Move your body. Go out there, play some sports, walk, go to the gym, whatever it takes to get the blood flowing through your body, get more oxygen going in. There's a record number of studies that indicate when you move, you increase your longevity. Number 3, stop smoking and drinking sodas. If you can't stop, at least slow down, because that will improve your health greatly. See you soon.